Tumor regression and allograft rejection after administration of antibody PD-1. My name is Daniel Ocampo. Definition: the programmed cells DID1 pathway has become attractive therapeutic target in numerous cancers. PD-1 was first characterized as a marker of apoptosis and is now known as an important immune checkpoint that regulates T cell functions. PD-1 is wide expression of tumor-infiltrate lymphocytes, particularly of exhausted T cells. Its ligand programmed DID1 ligands is mainly expressed on tumor and in many cells, such as dendritic cells, macrophages, myeloid-derived suppressor cells, and B cells.
As a scientist, I specialize in cancer immunotherapy. My work, and that of my colleagues, is to figure out ways to stimulate the immune system to kill cancer. To understand this concept, let's talk a little more about our immune system and how it works. Taking a look inside our body, all of us are born with an immune system that acts like the security checkpoint at the airport. Our immune system is like a high-tech full-body scanner system that protects us from things that are harmful. In the immune system, T cells have receptors that scan cells to distinguish between normal cells and abnormal cells, like virus-infected cells. Once detected, abnormal cells are attacked and removed by T cells. T cells also identify these cells for future recognition. The same T cells also play an important role in protecting us from cancer. Cancer cells are normal cells that have mutated. The more mutations cancer cells have, the more easily they are detected. Until recently, we didn't understand why T cells were detecting these cancer cells, but not destroying them. But on a closer look, we've made some revealing discoveries. We've learned that one of the ways that cancer cells get past the security system is with the help of a molecule called PD-L1 that is found on the surface of cancer cells. PD-L1 is almost like a disguise that allows cancer cells to remain undetected. PD-L1 basically hacks the T cell scanning system by jamming the signal to parts of the T cell system called PD-1 and B7-1. Think of PD-1 as a sensor that's part of the T cell scanning system, and B7-1 is like an alarm that issues an alert when something is wrong. When PD-L1 hacks the system, it prevents it from doing what it's supposed to do. In other words, it may prevent T cells from destroying cancer cells. Scientists have been working on fixing this problem and have designed molecules to target the PD-L1-PD-1 pathway. You can think of cancer immunotherapy as kind of like a software update for your immune system. Early studies suggest that by targeting the PD-L1-PD-1 pathway, T cells may be able to detect and destroy cancer cells. Let me show you in more detail. T cells have receptors that allow them to recognize cancer. Cancer cells can prevent elimination by turning on PD-L1. PD-L1 deactivates T cells by binding to PD-1 and B7-1. Blocking PD-L1 from binding to PD-1 and B7-1 could prevent PD-L1 from communicating with them. When this happens, T cells may finally be able to respond and kill cancer cells. Clinical trials are currently underway to understand the effects of trying to block the PD-L1-PD-1 pathway in the body. We are committed to studying cancer immunotherapy so that we can continue to find new ways to harness the immune system to fight multiple types of cancer.
Application in medicine. Reported case. A 57-year-old woman underwent kidney transplantation for a deceased donor in 1989. She received standard long-term immunosuppressions, including cyclosporine and prednisone. She presented with metastasis cutaneous squamous cell carcinoma in March 2014. Kidney function remained stable after reduction of immunosuppressions to 50 milligrams of prednisone daily. Her cutaneous squamous cell carcinoma progressed first durante cetuximab therapy and durante tremelimumab therapy. Her tumor containing a loss function of mutation in NF1.
PD-1 is a chemical, and PD-1, by the way, stands for programmed death 1, which is a bit of a misnomer. But it is a molecule that exists on the surface of mostly our immune T cells. You can also find it on B cells, by the way, and rarely on some other kinds of cells. But it's predominantly on the immune T cells, which are the principal cells that fight cancer, or can fight cancer, and it acts as a brake. And one of the problems in the cancer state is the immune system can be hugely suppressed in the cancer state. Tumor cells are very good at evading and avoiding immunity. So what happens is the PD-1 gets increased on the immune cells, which effectively puts the brakes on the immune system in the cancer state. And it happens particularly in what we call the tumor microenvironment. So almost diabolically, the tumors will increase expression of a substance called PD-L1. PD-L1 is the ligand, meaning it's the substance that binds to the PD-1 on the T cell. So on the tumor you have the PD-L1, it binds to the PD-1 on the T cell, links to it, and it suppresses the immune response. It's almost diabolical. The cancer cell contains within it the ability to suppress the very reaction that we mount to get rid of it. So think about how diabolical that is. And blocking that interaction is what happens when you use the antibody. And it allows the immune system to proceed in the way that it should have, which is to clear the tumor.
Pros and cons. Pros. Administration of anti-PD-1 was considered on the basis of her poor candidacy for cytotoxic chemotherapy. Performance status of 2 on a 5-point scale with Hater score indication great disability. At 2 years, overall survival rate of 40% among patients with metastatic cutaneous squamous cell carcinoma counts. The risk of immune-related toxic effects associated with an anti-PD-1 including kinase allograft regressions.
Well, I think as a scientist, you always hope that something that you discover will make a difference, never really knowing whether that will be the case or not.
Immunology has really promised to cure cancer for 100 years, but you couldn't go into your doctor's office and get an immunotherapy. CTLA-4 opened the door, and now PD-1 has really kicked the door wide open. Well, we identified the PD-1 ligand pathway, which turns out to be the major way that cancer turns off the immune response.
Dr. Hangzhou actually first cloned PD-1. And Gordon Freeman and Arlene Sharp, they actually helping identify how PD-1 binds to PD-L1, which we clone it. We independently work on receptor and ligand, but we don't know this tool is relevant. Okay. Then Gordon Freeman and Arlene Sharp actually link them together.
Well, our collaboration all started with a molecule called B7.
Gordon would clone the molecule and it's like, let's see how important it is. If we eliminate it from the immune system, does anything change?
Identifying the receptor-ligand interaction is like seeing a lock and a key relationship. And what we learned is this identifies the drug target, and it lets us then make a drug that keeps the key from inserting in the lock.
And we now appreciate that the tumor microenvironment has many layers of immunosuppression, and this pathway is a key mediator of these inhibitory signals, and that if you release that brake, then those T cells can enter the tumor and kill it.
When I was a student, actually, we learned from textbook talking about the immune system. It's unlikely going to cure a large tumor, especially late stage metastatic cancers. Now it's not true anymore. I think the textbook need to be rewritten
I do a lot of teaching of medical students, and I give a lecture on tumor immunotherapy. Early on, it was all of this hypothetical, and then it was with great joy that I had to rip up my lecture notes and start over, because now there are actually concrete examples of success.
This is transformative. This is the best thing going. 10 years ago, if you asked a pharma company to develop an immunotherapy, they would have been really resistant. And the Cancer Research Institute has played such an important role in funding this generation of work, which has led to where we are now.
Issue regarding Ecuador. In Ecuador, immunotherapy, also called biologic therapy, is a type of cancer treatment designed to boost the body's natural defense to fight the cancer. It uses substances either made by the body or in a laboratory to improve or restore immune system function.
Number 4. Advances in immunotherapy for cancer treatment.
Using the body's own immune system to fight cancer isn't something new, but its advancement towards a cure for cancer is. The market for immunotherapeutic cancer therapies has seen an unprecedented number of FDA approvals. One of the most notable advancements is joint therapy, the integration of immunotherapy and chemotherapy in a sample of patients with metastatic, non-squamous, non-small cell lung cancer. Joint therapy has been incredibly effective, more than doubling the cancer response rate from its rate with chemotherapy alone. Other innovations on the immunotherapy front involve therapies derived from T cells. New forms of engineered T cells have exhibited enhanced anti-tumor activity targeting antigens on tumor cells, allowing the body's immune defenses to attack the cancers within a patient. The agent with the most promise in 2019 is that of a T-cell receptor, TCR, T-cell therapy developed for use in liver cancer, the world's third most deadly. With a near-daily discovery of new immunotherapeutic targets, it is the hope that effective therapies will soon exist for all tumor profiles.
Conclusion. The anti-PD-1 can be highly effective against cancer arising in the context of chronic immunosuppression. Also, the PD-1 pathway may be critical in maintaining the partial tolerance that prevents the T-cells mediated allograft rejection.
The PD-1 and PD-L1 blocking drugs work, they're most active actually at the tumor site. And this makes them very different from anti-CTLA-4 ipilimumab, which has a global impact on the immune response. So when we're looking for markers to help us select patients who might be more likely to respond, or even if we're looking for other molecules that we should be co-targeting in combination regimens, for the PD-1 drugs we look in the tumor itself. And so we look at you know, what factors, what cytokines, chemokines, what cell types we find in those tumors, and we correlate them with the clinical outcomes. So we published early evidence showing that there was a relationship between tumor expression of PD-L1 with response to anti-PD-1. So PD-L1 is the binding partner for PD-1 that's expressed on activated T cells. This marker, PD-L1, did not seem to predict responses when anti-PD-1 was combined with ipilimumab, but we might not really expect it to, because again, ipilimumab has a global impact on the immune system, and so markers such as PD-L1 may not be relevant to ipilimumab. But this hopefully gives you an idea of the complexity of you know, our challenge now to find these markers that will help us refine these treatments.
Thank you.